good for the patient. And the very first question that comes, and what we're going to look at with the right patient, the tips and tricks, and I'll show you a video of how we actually do it and walk through it. And the question is, why do we treat perforators? Because there's evidence that the incompetent perforator veins play a major role in the pathogenesis. And we talked about it yesterday with the pressure from the deep system coming through the incompetent perforator. And as many as 66% of limbs with the skin changes in the SEEP classification from 4 to 6 have an underlying incompetent perforator that's in the game. And it becomes important to understand where the pressure is coming from and then stop that source of the pressure. A lot of times, treating perforators is like spot welding. And really about, I tell my patients this, I even show them pictures if I can, and with ultrasound at that time. So the foundational principle is you have the deep veins, you have the perforator, and whatever, if this valve breaks, it's going to flood a certain region. And you're going to see the changes in the skin and the tissues. If it's lipodermatosclerosis, ultimately the skin breaking down. And oftentimes, the pressure is a combination of saphenous truncal reflux, and depending on what the flow patterns are there. So obviously, if you have a large source of reflux from the saphenofemoral junction, you want to understand where else it's coming from. A lot of perforators actually are bidirectional, and there may be flow from a reflux above coming back into the deep system. Perforators can be either directly from the deep up to the reticular and affecting the area, or going through the saphenous vein and then coming out. Oftentimes, the one that connect into the saphenous, lesser or greater, if you connect that whole pipe, the rest of it will shut down. So I'm going to try and show you the ones that are isolated. Kind of understanding that a lot of the perfs will have an artery close to it, especially as you get closer down to the leg, posterior tibial. But you can see perforators in the lateral side of the thigh, medial thigh, below the knee, ankle, foot, depending on where the pressure is coming from. So as you create a map of the venous hypertension, sometimes you'll see, if you have a patient like this, that there's recirculation going on, the pressure rises here. In this case, the flow is out from here, going back in. Oftentimes, you'll want to do both. The key is ultrasound. Once you get the ultrasound and find out where the leak's coming from, you don't want to go deep, but you want to be able to hit this right at the fascia where it is. I'll try and do both, but oftentimes once you do the first one, the second one may or may not be easily accessible, spasm in that system, or just when you give the anesthesia. Oftentimes you don't need to mesent in that region, just enough around the tip, depending on what you're using. Want to make sure there's no obstructive process going on in the deep system. And when there is an obstructive process, that is really your relief from the deep system. So shutting things down at that time can make things worse. Again, something to be careful. So now the question is, which perforators to treat? Obviously, the ones that have reflux. More than 500 milliseconds, some use a second. Size depends on whether the patient's standing, legs elevated, they're hydrated. So size is always not that important. But most of the ones that are refluxing will be fairly large. You'll end up looking at SEEP 4 to 6. However, you saw some cases yesterday as well, where if you have an area that's being fed by the pressure, whether it's telangiectasias, reticular, or even varicose, you can still shut down the perforator as part of your normal treatment, so it's not only for deep wounds. Traditional treatment, open surgery, I don't think I recommend that, or the SAPS transfascial procedure. Some of these are really outdated now. Ultrasound is the absolute key. If you can't do the ultrasound, can't identify it, treating it becomes hard. The only FDA-approved device is the Covidien and Medtronic RF ablation device. Lasers can be used, it's off-label, and I know certain companies have gotten into trouble for trying to market that. This is really spot welding, so with ultrasound you find where the spot is. They have a certain technique that they propose, but most operators will find a way to adjust it to what works for them and how much they need to use. Could you play that video, please? So it's an actual case as I'm doing it, so I'll probably help out. You got the volume on that, please?
So I have for you now is a show you perforator ablation. So there's a refluxing perforator. It's a young lady who had greater saphenous vein, a lot of reflux, treated that. She's doing a lot better. Her pain, swelling has significantly decreased, but we're seeing that there's still some veins, some residual disease, and we can see a large perforator that's feeding an entire network of veins. Some folks like to just sclerose that with foam, but I don't like to do that because the foam goes into the deep system. So we'll do an ablation of that segment just at the fascia, which we'll look on the ultrasound in a minute. So I'm doing the ultrasound now, and you can see on the screen in a moment where I find the perforator, and that's leaking into the large branch, and that branch obviously goes up and is feeding into a whole bunch of other veins, that varicosities and reticular veins. So I'm going to come back and then take care of that perforator. So it's very important to identify where the fascia is and where exactly that perforator is feeding in. And I can see the fascia right there, and that's where we're going to go in with the ablation. So I've adjusted my probe position so that the vein is at the edge of my screen. As you look up on the screen now, you will see that there's the fascia, there's the perforator coming in, and I will now position my needle in such a way that it goes right into that fascia. So this is how it will be once it's inside, along that's the angle, that's the pathway, and if you look at the screen, or the ultrasound screen, you'll see what I'm talking about and how I want to position that, and that's how I'm going to go in that direction. Yeah. So I'm giving lidocaine a little distance away so that I can get into that frame. And if you look at the screen on top, you'll see where the ultrasound, the lidocaine is coming in. And that's where I'm going to bring in my fiber from that angle. So with that angle now, I'm going to go in. If you look at the screen, you'll see I'm now basically spearing that portion. And the reason I know I'm in the perforator is when I look at the machine below, you'll see that the impedance is in the 280 range there. And that's when I know that the impedance is low. If I'm outside, the impedance would definitely be much higher. So oftentimes I should get heme coming right back, but I may not. And that just means that I have something at the tip of the needle, but as long as the impedance is good, I know I'm in good shape. And if you look on the screen, you'll see that my needle tip is right at the fascia, and the heating element is right at the level of the fascia where I'm moving the tip of my fiber. So I'm going to give a little lidocaine now right around the spot. And so now if you look at the screen, you'll see I'm giving the lidocaine right around the tip where the filament is and where I'm going to do the actual heating.
That ultrasound.
And one of the things that happens if you look at the RF generator below is as soon as I give that, the impedance drops further. And I know that I got adequate anesthesia around it. The assistant then presses on the RF power button. She keeps it on there in case the patient feels something, stop it right away. So far nothing, because that is a good 83.6 degrees centigrade. If she felt it, She'd either hit me or tell me, one of the two, but definitely at least scream a little bit. And so far so good. The assistant takes a finger off that, it will go up to 4 minutes. And if for any reason this is in the wrong spot, as in not still within the blood vessel, the impedance goes up and the machine stops by itself. So you'll see as the seconds go on, the impedance has stayed in that range. And we'll go back and look at the ultrasound screen, and you can see the location where the heat is being applied, and it's right in the spot where I want it to be. So you can see we're now at just about 2 minutes, and if we go up to the ultrasound monitor, we'll see we're in the same spot, and that is still continuing to apply the heat, but you can see the coagulum around it and the echogenicity. If I pull this back or it's in major tissue, the impedance would go up and the machine would stop on its own. I do this at 4 up to about 4 minutes. Occasionally, if there are branches around it, I'll foam them at the same time, but not today. We'll just ablate this for now.
You can stop there here, please.
So as you see, we're starting to reach just around 4 minutes here. And if you look at the ultrasound now, you'll see that the branch that we had before is definitely not.
Excellent, thank you. So as you can see here, oftentimes one important trick is if you're going to give foam, I kind of look at it as spot welding, so the foam won't go deep in. And then if there's a network, I get that whole network with foam. If you're going to do that, you want to put the butterfly in first, because once you apply the heat, there's spasm, it's very hard to get into it. Oftentimes you may have a network of 2, 3 different perforators in the region. If you're going to do that, sometimes you'll get in the second one, but you may have to stage it because you won't see the second one as well. If there is a wound, I would not recommend that you do it through the area that's infected. Maybe like Dr. Bush does, put the foam first, get that area, get the wound to heal. One case that I did, and I think I mentioned this yesterday on the panel, we went through an area that was lipodermatosclerosis, very significant, big perforator, and he got an infection that kind of never seen before. It almost went down all the way to his muscle. It took him months to heal. So that's a word of caution. The foam is all the standard foam techniques you've heard, Sotradecol, polidocanol. You can use some of the newer ones. The real issues are watch for the adjacent artery. You can hurt the skin, be careful about that. Make sure the deep system is patent. Don't go through a contaminated area. So choose your patients carefully. There's a lot of different options. Wanted to stay on compliance, so we didn't talk much about laser, but there are enough people who use lasers, including myself. We can put the fiber through the needle itself. I don't think anybody really does open surgery on this anymore, anywhere. But ultrasound, doing it yourself is absolute key, and going from there. And depending on what you're treating, but most of the time, I will do the truncal lesions first, make sure the overall pressure has decreased, and go from there. Thank you so much.
All righty, Romi, thank you very much.